It's important in terms of prognosis also, and I will talk about it as I go along. So, certain children who are born with certain disorders or immunodeficiency syndromes are more likely predisposed to have ALL. What we see here, why I have highlighted Down syndrome is 10 times associated with ALL. A lot of the people who will, have Down syndrome will end up, developing ALL later in the childhood. And this is important also for us guys in terms of the board review questions. So we might have a case scenario where they will present us a child with Down syndrome, and then they can ask us anything about ALL, what might be, high risk factor in a child with Down syndrome. The other ones which are not as important are neurofibromatosis type 1 and ataxic telangiectasia. And other important risk factors are radiation and chemo. So we have to look here. Chemo, basically what we guys think of chemo is it cures you. But we also have to take into consideration when you give chemo, the person becomes immunodeficient, and you're more likely predisposed to have infections or even leukemias in certain cases.
I just want to add one thing, not to leukemia specifically, but since you mentioned board questions, remind me something. Very common in boards, they ask you the question, which is the most common cancer or tumor in kids? And they'll give you Wilms, neuroblastoma, astrocytoma, and ALL. What you have to do is read the stem very carefully, because they will change just one word, and it changes the correct answer. They could ask you, what is the most common malignancy in childhood? Shayar said it's ALL. What is the most common solid tumor in childhood? Astrocytoma. What is the most common solid tumor outside of the CNS? It's Wilms, followed by neuroblastoma is number 2. So the answer changes with the same multiple choices depending on the stem. So you just got to be careful with that. Why that would make you a better doctor if you didn't get fooled by the question, I don't know, but that's a question to ask board exam writers. Why is that an important nuance to know? The bottom line is you're going to get tissue, and the pathologist will tell you what it is. But that's the way, and it'll be different parts of the body. So, but those are things that show up I've seen on board exams and stuff like that. So just be careful how you read the question.
So this slide talks about the childhood ALL. ALL is lymphoblastic, meaning it can involve B cells or T cells. In terms of the age, they are really important. In the children, it's predominantly you see B lymphocytic ALL. Whereas as your age increases, especially in the adults, T ALL will be much more common than the B ALL. So how would the patient present, with the ALL? So what you would see in this patient will be basically pancytopenia is very common. The patient might have pallor, anemia. You can just look over the skin. It will be blue. The child will be lethargic, very tired. And the child is also, because of the low platelets, predisposed to bleeding disorders. The child will have petechia. There will be mucosal bleeding. Nosebleeds are really common in people with ALL. So, and another thing is infections. Why infections? Because the neutrophil counts are really low. The child might have a normal white blood cell count, but the neutrophils will be really low in the people with ALL, and this is what will predispose them to infections. And other non-specific symptoms, what do they include? They include fever, night sweats, headache, even weight loss is really common in ALL patients. And another thing which is not specific but really common in ALL is joint pain or the bone pain. Why does it happen? Because the tumor is in the bone marrow. So basically it can go the tumor can metastasize into the joint spaces, and it can also cause the periosteum of the bone to elevate, which can give the bone pain. And the bone pain can basically happen anywhere depending on metastasis, where the tumor has metastasized. On physical examinations, when you do the physical exam, 2 things are really what we should look for. Hepatosplenomegaly is really common. Sometimes it's massive. We will also see lymphadenopathy. It's non-tender. The patient will not see any pain. It's solid mass, and mostly cervical lymph nodes are affected more than other lymph nodes. So this basically slide summarizes the previous slide. So basically these are the B symptoms: fatigue, loss of appetite, lymph nodes will be swollen but non-tender, and hepatosplenomegaly. Other symptoms, there can be petechia, bruising, muscles can be weak due to the bone metastasis. Lung involvement is not that common, but sometimes the tumor can metastasize and the patient will present with shortness of breath, especially upon exertion. Next. So, how do you diagnose? There are many criteria for diagnosis. This is what any person with those symptoms in a childhood